First talk, I'd like to invite Dr. Vandana Nath. She's from Raghudipai Hospital, Ahmedabad. I'm Dr. Shail Vasavada from Raghudipai Hospital, Ahmedabad. And Dr. Vandana Nath will be talking to us about how to approach from the refractive point of view in a patient having pterygium along with cataract.
Good morning, everyone, and thank you, Dr. Shail, for including me in this course with such an august faculty. And thank you, the people in the audience, for being here so early. So, all of us have always and quite often faced this situation where we are going to operate a cataract, but there is also the comorbid condition of a very irritating but a very common problem, that of pterygium. So, how do we know whether this pterygium is going to impact our cataract outcomes in the forms of our biometry and the choice of IOL? And if so, what do we do about it? The most important thing would be the preoperative evaluation, where we are not only going to evaluate the cataract and perform a perfect biometry to get a minimal or negligible residual refractive error and the choice of IOL, but we need to evaluate the pterygium as well in terms of its site, size, and the grade of pterygium. So we go back to our residency days, and the history is the most important part. How long this patient, is the patient first of all aware that he has a pterygium? How long the pterygium has been in the eye? Did the patient notice whether it's progressing? What is the patient's visual requirement? What are the visual tasks that he needs to perform during the day? The status of the fellow eye is very important. What has been done in the fellow eye or not yet done? And of course, we cannot undermine the importance of counseling, good counseling regarding the patient's eye and what we are going to do. So there are three surgical options. One, first we do only the cataract surgery, leave the pterygium as it is. Operate it later if it progresses. Do only the pterygium first and at a later stage do the cataract surgery. Or third is combine the cataract and pterygium surgery. We'll take the first option and we are going to discuss, these are our own cases that we have performed and counseled for these, where we have done only the cataract surgery. This is a 76-year-old lady with hardly any visual activities and demands. She has and the left eye, she has had a toric IOL a month ago. And while we may want to immediately jump onto this lovely grade 3 nuclear sclerosis, there is a pterygium lurking there, where we can see it's a atrophic, thin, small pterygium, which is not so-called impacting her visual field at all. Ideally, while measuring the keratometry, which is perhaps the most important part of the biometry, more than one keratometer, at least 2 keratometry readings which are repeatable and reliable should be done. Because we know that all pterygia induce some kind of astigmatism. So we want to know the magnitude and the axis of the pterygium. We want to know the regularity. So in addition to the 2 keratometers, we should do a topography as well, if not a Scheimpflug imaging. So this is the kind of regularity that we want in a cornea, in which we are going to put or plan a toric IOL if there is significant astigmatism. The typical bow tie pattern that you can see here. So in this case, the keratometry showed a minimum astigmatism, but it was against the rule. So we expect a 0.5 to at least a 0.75 diopter of astigmatism. And this pterygium, as I said, it not only causes a little irregular astigmatism, but higher order aberrations. This is the aberrometry profile of this patient. And if you can see these higher order aberrations, which is the coma and the trefoil. So be careful of these, and therefore the choice of our IOL would not be any high-end IOLs, the premium IOLs so-called. Because all pterygia, these are the studies that show that pterygium and its size have significant influence on higher order aberrations of the eye, especially on the coma and the trefoil. So in this patient, we went ahead with a simple monofocal IOL, and she had a reasonably good vision of 6/9 with a minimal residual astigmatic error. So at least our residual spherical error was taken care of with a good biometry. This is a very challenging case that we had, a 65-year-old male with a left eye cataract, absolutely does not want a pterygium surgery because he's a high-flying businessman and needs to travel a lot. Very, very active gentleman. And we noted that his mesopic pupil was only 2.5 mm and maximum pupillary dilatation was 6 mm. To make it worse, the other eye was operated elsewhere, and if you can see the central rings, there's a multifocal IOL, there's an iris chaffing that you can see, and if you notice here that there is a big pterygium here. And he has a full thickness macular hole with a very compromised visual acuity. So this made our task even more difficult. We did a Scheimpflug imaging with a good anterior and posterior elevation curve. And we did a topography to see if, because this pterygium was inducing at least 5 diopters of astigmatism, what is the next best thing we can do for this patient? Can we reduce his dependency on glasses in any way? So we were trying to see if we could correct this astigmatism in some way, and we did the topography. And if you notice this dotted line, I'm showing the arrow. This dotted line is his pupil, and within the pupil there is a reasonable bow tie appearance, so reasonably regular astigmatism that you can see. Plus his pupil was not fully dilated, so probably we could get away with doing a toric IOL, and we did optical biometry and used the Barrett toric calculator, which is incorporated in the LensStar, and we put a toric IOL T9, and his best corrected visual acuity with a minimal residual refractive error, and patient was very, very happy, even with that large pterygium in his eye. Option 2 is a stage surgery. So where the option 1 was where we left the pterygium alone in 2 situations. Now these 2 situations are where we do the stage surgery, where we do the pterygium surgery first, even though the patient had come to us for a cataract surgery. This is a lady with a fleshy pterygium, and she's showing a very high astigmatism. If you see the steep and the flat axis, which is circled in red, you will see the high astigmatism, almost 5 to 6 to 7 diopters of astigmatism, along with the higher order aberrations. After the cataract, after the pterygium surgery with a conjunctival autograph, we not only we lowered the astigmatism, we get rid of the higher order aberrations, and now she has a regular astigmatism. And we waited after the pterygium surgery for 3 months, did a toric IOL, and the patient was counseled about post-op surface symptoms, lubricating drops given for a long time, and unaided 6/9, a very happy patient. And this is just to show the surgery of the conjunctival autograft. I'll skip this since this is the autograph we use with the tissue glue, and I'll go to the next one. This was a recurred pterygium. She had this huge pterygium since 15 years. So I expect a lot of scarring in this eye, and only when her cataract was nearly mature did she come to us, and she insisted on getting both the surgeries done together. And we insisted that we would not do it together. With a BCV of CF1 meter, this is the post-op picture of the recent 1-week post-op where we did a big conjunctival autograph. And you can see the scarring on the cornea. Now this cornea is going to take at least 6 months to heal. So don't go ahead with a cataract. If you want to give the best visual outcome to this patient, do not try to undergo a cataract surgery immediately or together along with the same. But if you notice, she was so happy with her best corrected of 6/18 after the pterygium was removed. So this was another very rewarding thing for us. And we waited for 6 months and then operated her. But because of the scarring, we would not advise any IOL other than the spherical IOL, a non-aspheric IOL. So we put SA6080, and she was very happy with that. We kept a close watch for follow-up and kept assessing the cataract. And these are the studies which show that pterygium excision can significantly reduce the pterygium-induced higher order aberrations, and topographic changes take about 6 months to a year to stabilize. If pterygia are small, do not impact K readings, they can be left alone. The option 3 is a combined cataract and pterygium surgery. This we do not advocate as much as possible because you will not be able to give the best visual outcome to this patient. This is a patient with a double-headed pterygium, and she was always uncomfortable with her glasses. These are the higher order aberrations and the high astigmatism. This is the quality of her vision. The simulated E-chart shows you the quality of her vision, and such poor vision she had. We did the Scheimpflug, almost a 6 diopter of astigmatism. And if you see, this is showing, if you go ahead with this without removing the pterygia, it's showing you a 24 diopter T8. Okay. This is the surgery we did, and 2 weeks, this is post-op. All the aberrations have gone, her astigmatism is gone, the quality of vision has improved. And this is an example to show you that if we had done this simultaneously, if you had done the pterygium and the cataract simultaneously, you would have gone way off in your IOL power calculation. And this is the last case where, again, the same thing. And this is the surgery where we did 2 conjunctival autographs, 1 week post-op, the improvement, and this is post-op 10 days. So ocular wavefront aberrations constitute the most important part of the optical quality of the eye, and pterygia lead to deterioration of the quality. Treat each patient, each eye as with equal evaluation, with a very, very detailed evaluation, so that we can give our patients the best visual outcome. Thank you.
Thank you very much, Dr. Vandana ma'am, for this wonderful array of cases. And I think the important take-home message that I particularly learned was that we need to look at, like in any comorbid eye, we need to look at the severity of each disease. So if we find that the pterygium severity is much more than the cataract itself, then I think it's best idea to treat the pterygium first. And like Dr. Vandana madam showed, that along, not only does it help in improving the ocular surface, improves your cataract surgery outcome as well. And just removing the pterygium itself helped to reduce the higher order aberrations significantly to improve the quality of vision. But the first set of cases which she showed are the more practical ones, which we keep facing more often than not. Patient in their mid to late 60s, 70s who have had atrophic pterygiums and are comfortable with that and are not keen for any surgery. These are the eyes we need to evaluate more thoroughly, particularly for IOL power selection. And if you have a regular astigmatism on any form of topography, you can still consider toric IOLs also in such situations, but be careful before choosing that. Thank you very much, ma'am.